do this webinar a little bit later, but I'm sorry for that. Yes, sorry, Kåre was totally right. I try to be as close as possible to Jean-Pierre. It's therapeutically is normal, and so we try to help him. We're trying to support him and to develop, for example, the brain course to help him, to support him with that. And on the other side, I try to do the courses with Jean-Pierre to be close, the close courses like the BICADD, like this one, or probably also the Teach Your Crossroad course that I will teach in October in Holland, for example. So those are the more advanced, it's a little bit strange, but advanced levels Pierre taught the last years, and I'm trying to take over from that. Kåre asked me to do this webinar because in September I hope, cross fingers, to come to Copenhagen by plane, probably by train or probably by car, I don't know, but I'm trying to be there. First in August with VM6, and then later in September for this BICADD course. Probably a quick introduction from myself. I started in '95 with the physical courses. At that time, there were only 4 courses. And in 2000, I did start teaching. So I almost teach years. Don't say that too loud. But I still enjoy it. I'm still liking it. And so I hope also in this seminar to show you a little bit of my passion. On the other hand, I'm married, 2 children, and I have my own office here in Zwanenburg in Holland, very close to Amsterdam. And I treat there people from 0 years, from few months to 94 or 95 years old. It's a little bit now, less people, a little bit. I just started 2-3 weeks ago working after the Corona lockdown. So we are allowed to work, so that's not bad. So what I will do in this hour 50 minutes is to just go a little bit through, to guide you to this, through the course. And a lot of people ask me if the BICADD is the same as the MASP, the manual articular spine and pelvis. It's not the same. In this course, we do only the disc, cervical, thoracic, and the lumbar disc, and a little bit besides that, interesting muscles and the venous system. So there are no, we trying to be sure about that there is nothing double in those two courses. So MASP and BICADD are totally different courses. BICADD is, the name is made up of, created by Cathy. That's why you see it in the line, Barral Institute Clinical Application Disc Disorders. And we call it just a disc course. So, sorry. So just a little bit in general with the spine, just a little bit up. There are about 33 vertebrae, and they are 24 are rather movable and 9 are not moving at all. And interesting for us that there are 23 discs, and the 16 to 25% of the total height, sorry, of the spine. And we will see later that the disc thickness is rather different. So in the lumbar area, it's it's about 9 millimeters. Oh, sorry, that's strange. I'm trying to do something here. So with 9 millimeters in the lumbar area, with about 5 millimeters thoracic and 3 millimeters, sorry, in the cervical area. And we will see also later, I will discuss that there is a huge difference with treating the lumbar area and the cervical area. To be sure about it already, before we start, that in the thoracic disc, we have a technique for that, but most of the time we use the rib, and I will show you why, because there is a connection between the rib and this disc, but we will see that later. So to have a little bit of the general anatomy, on the left side, you see here the vertebral body and the anterior longitudinal ligament. Sorry, I will make a pen so I can make it pointed out for you. Oh, where is my, wait a second. So here the anterior longitudinal ligament, the posterior longitudinal ligament, and you see this nice connection with the disc. And that's also the idea why most of the protrusions, prolapses, are going to the posterior lateral side, of course, on both sides. Not at the same time, hopefully, but they go to one side, and that's because of this posterior longitudinal ligament. Then in between, so this is the spinous process, of course, transverse process on the side, the facet joints here in the middle, and then in the middle here you have this flavum ligament, and of course I will show you next picture. This is the spinal cord inside. You see more or less the same picture on the other side, with only the little bit the superficial supra and interspinous and intertransverse ligaments here and here and there. And still here also this flavum ligament. It's not always easy, but sometimes it gives some fibrosis, and it has a big impact also on the spinal cord and on the function of the vertebrae. Nice here, the nucleus pulposus. So this is the inner side of the disc, and this is the annulus fibrosis, the fibers that are more around. And most people, of course, know it, but I will show you later a very nice images with this cartilage end plate here in this area. Okay, then we continue to the next. So when we spoke a little bit more about the annulus fibrosis, it's the outer portion. It's the outer portion of the disc. You can see it very properly. The disc is in this area in the middle. It's ring-shaped, circular, with several layers, lamina. They call it lamina, and only the 1/3 outside of the outer layer is innervated and vascularized and is sensitive. And I will show you later some nice pictures of that to make that more concrete and to show you that better. Then you have the outer layer of this annulus fibrosis. You can see it very properly. You can also see the different concentric layers. They are from the collagen type 1, and they are crossing. You can see it very nice in this picture. And that means that those outer layer of the annulus fibrosis are connecting also with the both vertebral bodies. So it's not that there is a disc and there is no connection with the vertebral body. No, they are close connected. They are very close connected. And the outer layer is connected with the vertebral body, and in the inner layer, so inside the medial part, I will show you in the next picture. You can see it properly. So the inner layer is here more connected with this end plate area. And the outside, these layers, here on both sides, of course, are, as you can see, connected between the both vertebral bodies. This is still annulus fibrosis, but it's a little bit different function and is more connected with the vertebral bodies. So you can see very properly here the nucleus fibrosis, to go with this very nice picture from Jean-Pierre's book about the disc, and he wrote it with Xavier Delanoy. That's a professor, also osteopath, but that's not a professor. I'm sorry, it's a doctor, neurology doctor, and those they make these nice computer pictures. So inside here you see this nucleus pulposus, but then in French, nouveau pulpeux, and the central part is the nucleus, composed about 80 to 85% of gelatinous water jelly-like structure inside, and there are a lot of protogliadines, protoglycans inside this nucleus here in this area. And those protoglycans are like tiny sponges that has a high affinity for water, and they are responsible for a healthy young person water content about 80%. So inside this nucleus, there should be a lot of water. When you become older, it becomes a little bit more dehydrated because all kinds of reasons, but less water means less flexible, and it becomes a little bit more stiffer. So when you're young, of course, there is more water, there are more protoglycans inside. So this is I like this picture a lot. So the human in the middle here is the nucleus, and on the side the annulus. Very nice to show that. And you can see that if there is an axial load on top of that, on top of the nucleus will move, will push in all directions. So all the red arrows is the nucleus that is pushing to all directions. If you can see this man, but then think about it, it's water. It's a restrained water of the nucleus become incompressible because there is compression from the top, and due to the axial load of on the spinal column, and this axial load will transfer the forces downward to the lower vertebra and to create a pivot point. What you see is that the this immobile annulus on the side and the end plates, they're also immobile. They are resisting. So slowly by slowly, it becomes transferred, these forces, to the lower vertebra. And because all the pressure on this nucleus, because all the pressure on this water, you can see that this nucleus turns into stone if there is enough water. So if there is less water inside, and of course it's not really stone, and it becomes a little bit less easy to get force through this nucleus, annulus, and the disc, and then to force all the forces to the lower disc. So it's like a closed hydraulic mechanism inside this disc. So it's much more fine, it's much more sensitive than what most pictures showed. When you see in the past in all the anatomy books, you see a vertebral body, you see a disc and another vertebral body. That's it. Now it's so much more complicated. It's so much fine-tuned, and that's why when we use techniques to work on the disc, it's not to push something back. It's just to help the physical elasticity of the disc hit herself or himself. So I always like nice pictures, just to let the cat sleep. We will speak now a little bit about the end plates, and that's also a little bit more complicated than we think. So we have a vertebral or cartilaginous end plate, and a subchondral bone or end plate. And I will show you the picture because it's very nice to see this. So we have the intervertebral disc here. We have the end plate, the cartilaginous layer. I'm sorry for that, my bad English. And here the end plate on the bony layer. So that's on this area. So you see you have different layers. And of course there is no, in general, not just a big space in between. But there is no firm connection between the cartilaginous end plate, and the subchondral plate. So in between them, there is some, of course there's connection, but it's rather soft. And if there is a mild trauma, then you can have directly separation of the end plates from the vertebra. And I will show you why that is so important, that they are good connected. Because the major function of the end plates is that, that they act as a semi-permeable membrane. So the disc itself is not directly is not directly. There are no arteries directly going to the disc, it happens by diffusion from the vertebral body through the end plates, so from the vertebra through the end plates, and they go inside the disc. So nutrients and metabolites diffuse into the disc from the capillary blood of the vertebral body. You can see here all the blood and all the small capillaries. So all the nutrition comes in from here. And on the other hand, they also allow the waste products to diffuse out, and that goes out via veins. You know, when there are arteries, there are always veins. Not in this picture, I'm sorry, but the veins plays an important role for the disc, especially for the water part of the disc. And what also happens is that those end plates prevent the larger molecules, like the proteoglycans, from diffusing out of the annulus and the nucleus. And the proteoglycans are like sponges. They're very important to connect with the water. So the less proteoglycans you have, the less watery the nucleus and the annulus will be. So the end plates, they have small, wait a second if I have this picture, yeah. So the end plates have very small channels called marrow cavities. You can see them here and here and here. I don't know, I hope you see this red part. So those small channels help to get this nutrition in, the waste products out, and they are so small, they should be so small, but the proteoglycans, the larger molecule, stays inside the disc. So as long as those channels are open, everything is functioning properly. There's a proper diffusion, there's a proper nutrition, and there is a proper waste of removal of waste products. So if there is a mild trauma, it can have an impact on those end plates, and you will see that those channels are not all open or become smaller. So slowly by slowly, the nutrition becomes less, the waste products cannot get out of it, and the proteoglycans can go out. So it's a very important system to get everything in a proper way, and it's a very complicated system too. So if we continue to the disc innervation, what I told you before, only the outer 1/3 is innervated, about 3 to 4 millimeters in depth. So only the outer layer is capable of transmitting pain, so that's helpful, and that's also logical, because otherwise, with all the compression on the nucleus, and you have pain fibers inside, every time you do that, you got pain. That's not what we want. So that's why there is only on the outside 1/3 layer you have this innervation. So the pain signals get out of the disc and they go to the sensory cortex of the brain. And that's the part of the brain that translates these pain signals into the feeling of the pain. So that's why you feel this pain, and you feel that in specific areas. Most of the time, you don't feel it directly in the disc, but to the areas very close by. And to be sure about that, the inner 2/3 of the annulus and the entire nucleus are completely avascular and aneural in a healthy disc. What sometimes help, oh no, I will talk about that later. Yeah, that's it. Okay, perfect. So interesting. So we speak about the 1/3 outer layer, and each region of the disc have different nerves. You can see this on this amazing picture. I think I found it an amazing picture. So on the posterior part, in this area, so on the posterior part, you have this connection with the posterior lateral disc with the innervation by the sinusoidal nerve, and that's also closely connected with the oh, what's going on there? The lateral disc is innervated here on the side by the ramus from the sympathetic chain, and the anterior part of the disc on this front here is innervated also by the sympathetic trunk directly, and this is from the I heard someone on my mic, Kåre Nielsen, and the posterior and posterior lateral part is innervated by the sinovertebral nerve. So you see there are different discs, but only the 1/3 outer layer of the disc again is innervated, of course, on both sides. Of course, every patient, every complaint, every treatment is different. So what we show here is a general order that Jean-Pierre likes to work with the disc. So he first starts with the skin, and we'll show you with of course, with the nerve fibers, the cutaneous nerve, and then he goes a little bit. Now it's not deeper, but more the neuromuscular fibers inside the erector spinae muscle. Then it's interesting to work with the organs, then the disc, and then finally the vascular system, and especially the venous system, especially the vein. And in the lumbar area, it's most of the time also the renal and the lumbar vein that are very interested for us. Of course, you can. It's just a guideline. It's not a rule. It's not a law. So depends what your listening shows you. Just depending what your general listening, your local listening, and your testing shows you to know the sequence of your treatment. But this is in general, when Jean-Pierre sees when he's working with a disc, this is in general the sequence that he uses. So we start first with the cutaneous nerve. I just try to go a little bit through it, and I will try to add some extras, of course. But so first the cutaneous and the muscular nerve branches. Wait a second. So it's interesting for us that the medial branch on the right side, the medial branch of the dorsal ramus becomes the cutaneous branch. So that means that this nerve, this is the medial branch here, the medial branch from the dorsal ramus, creates this nerve, this cutaneous nerve, which is innervating the skin. So you can see here the spinous process. Can I use another color? Of course I can, because I like that blue. So this is the spinous process here in this area. So what we do to work with this cutaneous nerve is to be very close to both sides, depends on what you want to do, on both sides of the spinous process, and just to be on both sides of the nerve to release the fascia around the nerve. Try to feel where it comes through and release this area. And and that's interesting, if you follow the medial branch in this area, wait a second. Always nice to have such nice colors. Purple, can you see purple? Yeah. So if you follow this, you go to the dorsal ramus, and finally it goes back to this area, and you see that other connections here are with the sympathetic chain, with the sinovertebral nerve. So if you work on this cutaneous nerve, and later when we work with the neuromuscular nerves, you will see that through this, you have an impact, you have an effect also on the disc. That's why we start with this area, of course. And on the left corner, you see this nice picture to show the sinovertebral nerves inside this outer layer of the Annulus Fibrosis. And the sinovertebral is also connecting with the dorsal root, with the recurrent nerve, but also here, you can see it on the left corner here, with the medial branch of the dorsal ramus, which is also making this a cutaneous branch. So that's why it's important for us to work also with this cutaneous and neuromuscular fibers to have directly an impact on this area, sorry, on this, where is my point? Oh, here, to have directly an impact on this area where there is a lot of inflammation. So don't directly jump in the disc if you could do that, the body shows it, but most of the time, because there is so much tension around this area, that you first need to release that before you can enter the disc itself. I like this picture. It's an amazing picture with all those dogs, and I think they know what they want, but they have to stay cool. And this very, very brave cat probably is blind, I don't know, and no smell, because there are so many, about 20 dogs sitting here. But so the muscular branches of the dorsal ramus, that's the next picture. Oh, yep, next picture. You can see here this the dorsal ramus on this side with the lateral and the medial branch inside the muscle. And what I said before, you can see it probably better even here, that this medial branch has the in the elongation you have this cutaneous nerves. So most of the time we work more with the lateral branch of in the muscle. What we're trying to do more and more now is to avoid working directly on the nerve, because we noticed that the nerve is very, very sensitive. We knew that already, of course, but what we did before in the NM courses, in the NM2 and NM3, is that NM3 and NM4, sorry, too, is that we work directly on the nerve. Now, more and more, we are getting away from that, and we're trying more to work on the surrounding tissue, on the fascia that's surrounding the nerve. So we don't work directly on the nerve anymore, because we showed it's more effective to work on that area. So especially, for example, when you have a cutaneous nerve. So if you have a cutaneous nerve, there's always a hole, and it comes through this hole. Is it the proper picture? No, it isn't. So if I have a nerve, oops, so sorry, it's a nerve, and then this is better. This is a better picture. It's bad. So if you have this picture, we first want to work on the hole itself. So we want to work on this hole to open on all directions, because what a lot of times happen is that this hole in the fascia becomes narrow, and when it becomes narrow, it's squeezing the nerve. So you want to prevent that. So we're trying with our fingers, the fingers are the arrows, we're trying first to open more and more with the fascia, this opening, so the nerve can glide a little bit easier inside. And then the next step, most time, is that we work with the surrounding of the fascia of the nerve. So we put our thumbs or fingers on both sides of the nerve to work with the fascia that's surrounding the nerve. And if that's still not working, but most of the time, I think in 99.9% from the cases, it's okay. But sometimes you have to be on the nerve itself. And then when you think you're light, you're not light enough. You have to be lighter. So you just barely touching the nerve, and then you can work with it. But it's even the lightest touch is not light enough. So be aware of that, please. So don't see this picture wrong. This is because of the coronavirus. He already have the hand gloves on. This is his other hand. So just to be sure that we don't do anything wrong. But this is a nice picture to work with the lumbar area. So what we do is that we put the patient, in supine on the back, and so this is this part. Oh, here it is. This part is on my table. So it's a little bit strange, but what I do is I put my fingers on the spinous process. Oh, there's a little bit pointy finger. And I push in the direction of the arrow, because we have to be aware of the natural position, in this case of the lumbar spine. And that's also a little bit in lordosis. So we adapt, we compensate, we use our listening, of course, because not everyone is the same. Probably in my lumbar area, it's about 30 degrees. Probably someone else is 40 or 20 or 35 exactly. every time it's different, but to be sure that you use the lordosis, that you use the natural movement, natural gliding movement of the lumbar spine with 5 lumbar vertebrae. So you see the one in the middle, L3, is more or less straight, more or less 0 degrees, and then L2 and L4 is 15, and then L5 and L1 is more in 15 degrees, 15 and 35. Oh, 35, yeah. So it's moving up, but what I said again, it's a little bit different. So try to feel, use your listening in which exact position you need to work on this spinous process to have this effect on the whole spine. So, and we push, and at the same time we move the leg. So it's the patient is lying in supine on his back with one knee flexed. And so I have one hand underneath the spinous process and the other hand is on the knee, just trying to move, to feel if it's moving, to feel if it's gliding. And it's not, again, what I said before in courses, if you know me from the courses, it's not that you think, is it moving or not? No, it should be clear. So what you feel, dang, it's completely blocked. That's the difference. That's really a blockage. I will show you, I will talk a little bit more about that. But we need to work through the spinous process, and we'll see that also this abduction and adduction from the knee helps to feel this slightly movement of the lumbar area. What we do, we push. So what we do, we push the spinous process forward to get an idea of the mobility, but also we can go into the depth layer by layer by layer. You can see it also in this picture on the right side. So we push on the spinous process and be aware again of the lordosis, of the lumbar lordosis. So with every lumbar vertebrae, there's a different direction. Feel, please use your listening to be sure in which direction you push. But if you push, you see that there are different possibilities when you move in. So I go to the next slide because that's easier to, I think, for you. Wait a second. So when we apply the pressure to the spinous process from posterior to anterior, and of course I showed it, the test is in supine, but of course you can do it also in lying in prone position. So then from posterior to anterior. So when I push against the spinous process and I feel an immediate hard blockage, it means that their facet is blocked. That could be on both sides, could be on one side. There is no elasticity, there is bang, it's immediately blocked. Then if you go a little bit further, so there is no blockage, so there's no immediate blockage, but you come a little bit further, you come to the flavum ligament. Then one layer deeper inside, the posterior longitudinal ligament. And then finally, you can go to the disc and to feel its viscoelasticity. So I go back to pictures. So, sorry. I push on the spinous process. The first immediate blockage here, give you an idea of the facet, and it could be on the left or on the right, superior or inferior, but we have special techniques for that too. Then the next layer that you came across is with the flavum ligament. Of course, you have the spinal cord in between. Then the posterior longitudinal ligament, and then finally, in this case, it isn't shown, but here you have the disc. Finally. And it's important when you will, what we do in the course is that, of course, we are happy when you can feel the disc, the viscoelasticity. It's like you push against the balloon and you want to feel this balloon, this viscoelasticity of the balloon. You want to feel the viscoelasticity of the disc. Is it on the right side? Is it on the left side? Is it more posterior or is it more anterior? where is it that you can feel this restriction? Where can you feel this dysfunction inside the disc? And then we can use compression, decompression to work with. Okay, so I go to the next slide. Of course, I hope you know him, Jean-Pierre Barral. He's doing the test with the hands, what I said before, the patient supine, with the hand on the spinous process and the other hand on the knee. You push with your finger on the spinous process, spinous process, and with this hand you do an abduction and an adduction, abduction and an adduction. Just to push, and at the same time you move to feel if there is some movement, some mobility of this vertebral body. And again, you can see here on the lower picture, here down, when we push on the spinous process, we have, of course, the facet first, immediate blockage, hard blockage. If there is no hard blockage, but your next thing what you could feel is the flavum ligament, then the posterior longitudinal ligament, and then finally the disc. So sometimes it's about 7 to 8 centimeters deep before you reach the disc. If we put this specific lumbar test in our diagnosis, so like you know, we always start with the general listening. There should be a case, oh that's nice, case history in before. Sometimes I try to skip, I start to speak at the same time I write. So of course the case history is important, but in a lot of cases I like to first do the general listening in standing seated position. I want to do some tests, nothing very hard, but just to feel some things, to know a little bit more. I can do my local listening, some mobility testing, and then I say to the patient, I share what I found, and then slowly by slowly, of course, you do your case history, and you pick out probably the indications, contraindications, just to know. But to know nothing about the patient is most of the time easier to feel what's really going on inside. Because if some patient comes in your office and they say, oh, my back, my lower back on the right side is hurting, it's terrible. On the right side, in the low part, and I think probably it's the IS or is it SE joint, I don't know, but somewhere in that corner I feel something, it's in my right buttock. If you know that, and it's so sensitive, someone is coming and is pushing, sometimes it's pushing also on you, so it's coming to your buttock and you push there. It's not easy to be objective with your general listening, and with the general listening is seated and in standing position. With your local listening, it more or less, the patient push you already a little bit in that direction. And so the pain is in that area. So of course, the patient is in trouble and the patient is very serious. And of course he wants to be helped, but we are more helping him when we are objective, because then it's easier to feel what the body were really primal causes of this pain. And that could be in that area, but it could also be somewhere else. It could be something in the knee or the foot, or it could be something in the neck, or it could be something in an organ, for example, the kidney, or it could be the cecum or the sigmoid, liver. So it's very important to be open. Sometimes it's much easier to know nothing about the body, because then you are open for everything, instead of just focusing on that specific area, on the right SI joint area, so to speak. Another thing, especially with the lumbar area, what's very interesting is that we can use the straight leg raising test with inhibition. So if you do the straight leg raising, that means that you're lifting up. So I will try to draw something. It's not easy, but wait a second. I think I will surprise Gerard, a colleague from Holland, that I make those amazing drawings. You can see here, it's amazing. So this is it. And this is the right leg, and then the right leg, you just move it upward like this. And you, of course, you compare the left and the right side. The arms is also nice, and the mouth. Yeah. So, of course, you compare left and right side. One side is probably painful. So in this case, this is already with this leg, it's painful, it's shooting, whatever. So you can go back a little bit, and you can put your hand, you use inhibition. So you can put, you did your general listening, you find the kidney, you inhibit the kidney, and then at the same time, you move this leg again upward, and there should be a huge difference. So wait a second. So I do inhibition on the kidney here. Whoa, this big kidney, sorry for that. I do inhibition on top. And at the same time, I do this point. And what should happen is that this leg could go easily up. And most of the time, 20 to 30 degrees further up should make a difference. So if it's 1 or 2 degrees, that's not interesting for us. 20, 30, 40 degrees, that should be the difference. If it's too less, then it's not easy to make this change in there. So there are different possibilities to work, of course, with the lumbar disc. We test and we can treat in supine position, in prone position, like the picture here on the right side. This is, of course, in prone position. But we can also treat in side lying. And when you're in side lying, we can also use a rotation of the pelvis and rotation of the thoracic area to go into the depth. So always be aware what I said before about the lordosis. So, oh, this is this picture. Sorry for that. This is this picture. So be aware of the lordosis. And when you're doing in side lying, it's different than when you're lying on prone, and also different on supine. So be aware. Always use your listening, push and feel in which direction you can do the best. So for the treatment, you can see this in the right corner. Yeah, here it is. So to get the listening, you load the spinous process. We are on this area. We load the spinous process, and you push. So again, first blockage immediately facet. But in this case, if it's a facet, we do a different technique to release the facets. The next stage is the flavum ligament, but we want to go deeper. So we meet the posterior longitudinal ligament, and then from that point it becomes rather interesting, because then we start to feel the disc itself. Here it is. So we have the disc itself. So that side. It's always nice to draw. Huh? So we come against the disc. You see it. You visualize. You try to feel. You see in your head the anatomy. You know where the disc is, and you're trying to distinguish in which part of the disc is the problem. Where is the hard spot inside the disc? Where is the restriction inside the disc? Is it on the left side? Sorry, it's funny because I lose always my. So is it on the left side? Is it more on the right side? Is it more posterior, anterior, or is it more posterior? So you push through the spinous process. Look at this picture. Look at this picture, the spinous process, till you meet the disc. And when you meet the disc, you're trying to meet them in three-dimensional way. You're trying to visualize the disc, and try to focus on where is this hard spot inside the disc. Left, right, anterior, posterior. Try to feel, and we're working with the viscoelasticity. So I'm not pushing back the prolapse or the protrusion. No, it's just that I want to work with the disc, the viscoelasticity of the disc. And then if you see this small node on the corner, sometimes this pain, the spine, sorry, can feel freely, but it can still be a disc problem. So be aware of that. Now, of course, your listening should bring you inside. So you can feel the disc is moving, but your listening brings you still pushing inside in the direction of the disc itself. And then when you do this technique, you feel this hard point inside the disc. Important is that when you work with the disc, the pain will not immediately stop. I will talk about it later, because most of the time there is an inflammation in the nerve and the disc, and that takes a little bit of time. So what we're trying to do, what we're trying to accomplish with our treatment, is that we create the conditions, the proper conditions, that the body can use to free itself. I'm looking for a proper word, but I cannot find it for the moment, sorry. When you work on the lumbar area, always check the L1, L2, and L3, especially L2, because that is a part that we see a lot. And L2 is, you see that a lot because of the sinovertebral nerves, because the root of the sympathetic chain from L5, from L4, from S1 is to L1, L2, L3. So that's why you see a lot of L2, especially L2 is the key vertebra of the lumbar area. So a lot of times you see that with the L4 and of course, sorry, L5, it's not easy. And of course, S1, those discs, is a lot, most of the time you see them on MRI. But in a lot of cases, when you follow your listening, when you feel the body, the L1, L2 are restricted. Of course, L4, L5 is 1, 2, but your body, your listening brings you to L2. But first release L2 and you come back to L4, L5 as 1. Our general goal is to harmonize the spinal intracanal pressure. And we are not, again, we are not trying to move something, we're trying to work on the pressures. And on the pressures of the disc and the pressure of the intracanal pressure, the intraneural pressure. So we're trying to work with all those pressures inside the body. And what's important is that with MRI scans in supine, that's of course most of the time when people were getting the scan from the lumbar area, is that causes a lower disc pressure, and you cannot always trust those MRIs. That's the problems. So also in Holland, but this is from Jean-Pierre, those French physicians who are disc specialists have found that 70% of the disc herniations seen on X-ray and MRI are without symptoms. So don't focus on herniation. Of course, the patient comes in with nice pictures, X-ray or MRI. You can see an amazing herniation, but try not to focus on that. So most of the time what I do in my office is that I first do my, so the people come in with those pictures. I don't want to see them. I just first want to do my diagnosis. I just first want to do some tests, and then I come to my conclusion, and then I want to see the pictures. Not before, again, what I said before, if I can see there is an amazing herniation on L4, L5, an amazing one, then it's not easy not to go to that area. So then the picture and the patient push me to that area. And what I want is to communicate with the body itself. Why is this herniation developed? So that's important. Okay, we go further. So of course, we also talk a little bit about muscles. In this case, the transverse abdominal muscle, and that muscle is interesting for us because it has a connection with the thoracolumbar fascia, and the thoracolumbar fascia is also connected. You can see this on this nice picture. The transverse, thoracolumbar fascia has 3 layers with the erector spinae in this area, with the quadratus lumborum, and also the psoas major, or the psoas muscle, and that is connected with the transverse muscle, transverse abdominis muscle here on the side. So what you can see is that the transverse abdominis muscle is connected with the thoracolumbar fascia, with the transverse and endothoracic fascia, the diaphragm. Where is my pointer? Here it is. Diaphragm, iliolumbar ligament, and they're all connected, and they're all creating maintenance of this good abdominal pressure. I still have problems with my mouse, which has a big influence on the disc circulation of the disc pressure. So the influence on the disc circulation and the disc pressure is very important in this case. So the disc problem, there can become a disc problem because of the adhesions, fibrosis of this thoracolumbar fascia. And that one is connected with the transverse abdominal muscle. And you see, especially, for example, after delivery, that there can be in this thoracolumbar fascia, or especially in the transverse abdominal muscle, there can be some small adhesions, ruptures inside this muscle. So immediately that has an impact on this whole abdominal pressure, and so a big impact on the disc via this via the pressure, and then you have a bad or less good venous circulation. And a good disc needs this venous circulation. We will see that later. We need this venous blood that goes away, because the body needs to get rid of the waste products inside this disc. So this you can see it here, very nice, amazing picture here with abdominal corset, with, of course, the rectus abdominis, and with the oblique externus, oblique internus, and of course the transverse abdominal muscle connected here with the thoracolumbar fascia, with the connection with deep layer with the psoas, here this area with the caudatus lumborum, and here with the erector spinae. So you can see this create this abdominal pressure, and this abdominal pressure is very, very important for the disc, and directly on the venous pressure, on the venous system, venous circulation, and so indirectly on the disc itself. So if there are any problems inside those muscles, what can happen because of a fall, because of delivery, because of the pregnancy, that can have a big impact on the whole abdominal pressure. And when you speak about the whole abdominal pressure, you have also a big impact on the disc itself. Nice picture, don't be afraid, you're far away. To speak a little bit about the disc pathology, a little bit, I will speak in the course much more about it, but in this just to give you a slight idea of it, something here. We speak about different types of tears, annular tears, especially in this annulus fibrosis, so in the outer layer of the disc. And you can have a radial tear, horizontal orientated, so that is this one. So it is the most common one. And then you have the smaller ones, the rim here on the side. They start a little bit on the side. They are much smaller, also most of the time horizontal, and most of the time only in the outer annular fibers. And that could go also to the nucleus. So the first one, the radial tear, goes from the nucleus outside. And sometimes it's rim lesion because of trauma, for example, can also go from outside to the inside. And then on the other side, on the left here, you have this concentric annular tears, and they splitting more or less apart this annulus fibrosis, those lamina that are inside the annulus fibrosis. And that tends to occur in the posterior and posterolateral region of the disc. And the problem is that on the outside, posterior and posterolateral region of the disc, you have the most sensitive part of the disc. So if there is something going on with these concentric layers, that could cause a lot of pain. And there's very small tear. So unfortunately, has a big impact because of the sinovertebral nerves. So what you see is that if we have this horizontal annular tear with the nucleus pulposus, it's going outside here. You see it purple, and most of the time to posterolateral, posterior part, with our friends here with the sinovertebral nerves. And there are a few things could happen. So biochemically, called the cytokines, the Nucleus Fibrosis goes through the passageway and created by the annular tear and comes in contact with the nociceptive nerve endings in the outer annulus, those from the sinovertebral arteries, nerves, sorry, and initiates a painful inflammatory process. So that's why you see here in the picture the red dots. Normally it should be yellow. In this case, they become red because of the inflammatory process, inflammatory reaction on these sinovertebral nerves. I think I'm come a little bit in sunshine. I will close my, wait a second. Oh, I'm still here. Yeah, second. So this is better, I think. Yeah, that's better. Now I'm a little bit dark, but that's even better. And of course, the second step is not inflammatory. It's the biomechanical change. And because of the annular tear, which causes a lot of a loss of the hydraulic pressure within the disc, and that changed the load-bearing effect from the nucleus to the posterior annulus. And what happens is that there becomes more pressure on the posterior annulus. Of course, you don't want that because, again, you have those sinovertebral nerves in that area. So you get now also a mechanical compression of the already inflamed sinovertebral nerves. And that may cause severe discogenic pain. So from two ways, you have a biochemical way and a biochemical and a biomechanical changes. So most of the time when a patient comes in with pain in his back, I said, to be sure, to be honest, you go also out with pain in your back. That loads a lot of the responsibility on my shoulders, and that makes it a little bit less heavy for me and also for the patient. Because of this inflammation effect, it needs for sure time to adapt for the body. So, and that doesn't happen normally in half an hour when you treat the patient. So mostly when there's this pathology, we speak about the bulging of 3 to 5 millimeters. That's not a lot, but it can be very, very painful. Most of the time it's a posterolateral aspect because of the position of the longitudinal ligament. I think you will remember this picture in the beginning where you have those in here, the vertebral bodies and the disc in between. And then when you have this amazing posterior longitudinal ligament, and you can see here the connections. So it doesn't go in the middle, but it goes to the sides. So what you see is that most of the disc is a little bit small on this side, goes to the posterolateral area of the disc, of the area of the herniation, because of the position and the local position connection of the posterior longitudinal ligament. What do we treat? We treat the viscoelasticity of the disc. Again, we don't push something back, we don't push the bulging back, we just work with the viscoelasticity. And when there is just a slight, only probably 1 millimeter, less bulging, it could make a huge difference for the patient. Over time, not after 5 years, but it is not the next day. It needs a little bit of time because the inflammatory process needs some time for the body to stop. Yeah, what's very interesting is that, of course, people come to you and they say, oh, I have pain in my L5, F1 disc or something like that. So most of the time you see also, of course, what I said before on the MRI, on the X-ray, L4, L5 are most of the time the most affected areas. But what you see, and you can see it here on the left with this small story. So, for example, when you're 15 years old, you fall from a tree or you fall from a wall, and that gives some tension in the disc at the level of L1, L2, for example, in this area. So you can see here a small point, not much, but a little bit. And of course, you are young and you are flexible, so the body has have a lot of space to compensate. But this area in this L1, L2 disc, it becomes a little bit fibrous and a little bit less elastic. Then, 24 years old, you will carry too heavy weight, and that would give some tension in the disc L2, L3. You can see here, there's a little bit of tension here, but still you have this impact here in this area. Then person is 45 years old and building a house and do some manual work, and then tuck, pain in his back. L3, L4 area, small tension in this area. And then later in life, because of a bad diet, because of a lot of sitting, working seated position, you get a more general tension in the disc at a level of L4, L5. And then what will happen is that there's a cumulative effect on all those discs by finally it gives a herniation at the level of L5 is 1, or probably L4, L5 in this point, and then goes to that area. So it's most of the time, it's not at once. Sometimes it is. Don't say that, because sometimes it's really one thing, but then should be a big one, or there's already a lot of compensation going on in the body. But what you see in a lot of cases is that the body is building it up, not deliberately, but it's building it up. It has a cumulative effect, so slowly by slowly, it creates some tension and more tension, and that's why you see most of the time L4, L5 is one disc problem. But when you use your listening, probably the listening says you have to work on the disc of L1, L2, or L2, L3, and then you have also this impact on the rest of this chain. So be sure that the body will tell you. So if you use your listening, the body will tell you. You communicate with the body. The body tells you what's going on inside on a non-verbal level. So that's why it's important to listen to the body, and not, of course, you listen also serious to what the patient said, but with your hand are the most, and the listening is the most important part for your diagnosis. There are some red flags. Of course, the one I have only once in my office, and I have my own office since '94 with a bowel and bladder dysfunction. I always ask, but happily no one said yes. And there are some excruciating pain, perineal loss. So there are a few things that are very important, but the most important part is to ask always about the bowel and bladder dysfunction. And there, of course, there are some risk factors with this generation. Genetics, your building, the vibration depends on your work, vertebral end plate, shape of that could also be changing, of course. What I said before, mild trauma, depends a little bit on what kind of work, what kind of sports you did, and a lot of sedentary work doesn't help either. Physical jobs with a lot of sweating, so a lot of bending and lifting is also not the most optimal for the disc. No, I was going to the next one. So then there's another part where you think what you can do is to work on the cluneal nerves, and also it's interesting, especially in this picture, that when you work on those cluneal nerves, those cutaneous ones, is that they have direct connections with superior, with the L1, L3 in this area, with the medial cluneal nerves is S1, S3, and the inferior also is S1, S3. And then you also have the hypogastric, it's also T12, L1. Interesting for us, especially the superior cluneal nerves and the iliohypogastric, so the ones here on the side, because they are directly connected with L1, L2, and L3. And what we said before, L2 is a key vertebrae of the lumbar area. So that's why it could be very nice. And there are also some research articles about the iliohypogastric and the superior cluneal nerves, that they injected it and have rather good results. But we already did using it with our hands to work on those nerves. So we work with those because you see the holes here, what I said before. So there is a hole here and there is a hole around this area because it comes from the depth to superficial. And first we want to release the holes and then we can work with the surrounding tissue of this cluniae nerves. So we don't work directly on the nerve, we work on to release the fascial ring, and we work on the fascia that's surrounding the nerve. And when we really want to work on the nerve itself, our touch is not lighter than light is not light enough, so to speak. So I think you know the ancient cat and the modern cat. It's a nice picture. And we can speak a little bit about the back part with the piriformis muscle. Very interesting muscle, also called a visceral muscle because it's directly connected with the most time with the bladder, but also with the organs inside the pelvis area. And what's interesting for us here is the sciatic nerve. So we will also work with this area in this course in the BICADD because we want to also feel the pulsation, of the superior and the inferior gluteal arteries. There's those nice arteries, because if those arteries are less palpable, and of course you compare left and the right side with each other, that gives an idea of the tone of the piriformis muscle. So when you work with the psoas muscle, with the piriformis muscle, you should feel a difference in this pulsation. Of course, you know that there are a lot of anatomical variations with the sciatic. Most of the time it goes underneath, like this picture. Sometimes the nerve goes in between, and sometimes it goes posterior of the piriformis muscle. So that is good to know that there are differences in that. Yes, and interesting for us also, be aware of that. So when you stand up and you bend forward, this sciatic nerve should move 4 to 5 centimeters. 4 to 5 centimeters, it should glide in your whole buttock and your leg. So be aware of that. And that's interesting for us, but more interesting is that there is also a transverse movement. So when you're bending forward, your sciatic nerve, so when you bend forward, your sciatic nerve moves in lateral direction. And when you're returning from flexion to extension, it moves, of course, the other way around in medial direction. It's a small movement, but probably even as important as the longitudinal 4 to 5 centimeter movement. So be aware of that, we do that in our course. So what we do is to work with the piriformis to feel if this nerve is gliding, and also from left to right, and also in longitudinal direction. I hope you become so curious about this course that you all come to join us in September. So to speak about the psoas major muscle, you can see it here. It's such a nice picture. I couldn't get it out of my presentation because there is so nice connection with the disc here. You can see here. So this is a disc. Here is also a disc. There are fibers from the psoas muscle to the disc, and this is of course the spinal nerve with a lot of fatty tissue around, and there is much more inside, ligaments too. So also that's much more sensitive, much more complicated than the normal pictures that we knew of. I already talked about this. So the venous drainage, the lumbar area, nice, because you see that there are a lot of veins. You can see here the spinal cord, so the spinal cord, and then you have the veins around it. So the veins helps to protect the spinal cord, help to enlighten the spinal cord, and then just beside the outside of the dura mater, you will also have the extra veins, and they are inside this canal, the vertebral canal, also to protect the spinal cord. So the spinal cord is protected from all different directions. You can directly see here also the veins, and there are much more, I can assure you that are also helping, protecting, supporting the spinal nerves in this area, and you can see it also in this area too. So that's why it's so important You can see it here again, but also to the other side, that all those discs are draining into the lumbar vein. And the lumbar vein, especially the lumbar vein on the left side, here you can see this, is draining into the left renal vein. So that's why it's so important that when there are complaints of the lower back, that of course your listening brings you there, the general listening, local listening, but also always check the left kidney, because that's so important for the drainage of the lumbar discs. So this is a better picture. So what we will do is to test, of course, with our normal techniques, to push up to feel if there is movement in the kidney, and of course we compare left and right side. But then when we want to work on the renal vein, we want to move the kidney in lateral direction, because that gives a stretching effect on the mechanoreceptors inside the renal vein, and that helps the renal vein. But as you can see, it also helps the lumbar, here, the lumbar vein. And you can see here, no, this is not properly, but the lumbar vein is the drainage blood vessel for the discs, for the lumbar disc. Very, very important, because otherwise the pH, for example, becomes too high. It becomes too acid inside the disc, and that doesn't help to stay flexible and supple inside the viscoelasticity for the disc. So it's important for the venous drainage, the relationship between the genital organs and the left low back vein, especially of course the left kidney. If there is a congestion, what will happen if there is a congestion in the veins? You get it gives more pressure on the veins and gives more pressure through the veins on the nerves itself, because normally the veins help to enlighten, help to protect the nerve itself. But now it's the opposite, it's just pushing on the nerve, and you don't want that. And what also is happening, you saw that on the picture, but I was a little bit quick on that, is that you also have this suprarenal veins that also drain into the left renal vein. And the suprarenal vein is coming, of course, from the suprarenal gland. And that's why sometimes when there is fatigue with low back pain, because normal it's a mechanical thing, so there shouldn't be any fatigue. But if there is fatigue included, most of the time you see that the suprarenal gland is involved, and that could be because of this venous drainage. So nice picture again of the left kidney here, and we want to move it to the lateral part. And on the right picture here, you can see these veins that are surrounding also the spinal nerve. It's surrounding also around the vertebral body, and for sure also the disc itself. So that helps to drain, but that should be clear and open. Yeah, what I said before, the thoracic spine, there are a lot of movements inside the whole thorax. The ribs giving the stability, so the ribs are rather important for the organs, for the thoracic organs. Every rib has 5 joints, and of course the ribs need this breathing motion, and it's very important to restore the elasticity inside the ribs, because if there's a hardness inside the ribs, slowly by slowly, it doesn't help to get the proper amount of oxygen inside. So when there is a fall on the thorax, the ribs are more important than the spine, because what happens is that when you fall, you're always trying to protect the front part and your spine. So what you do is you turn a little bit, so you're trying to catch the fall, the trauma with your ribs. So be aware of that. And I hope I have the proper picture. So of course, you know the rib, you know the sternum, you know the side. easy, we take more. And this is important because we have here the rib, and we have here the connection between the rib and the vertebral body, the costovertebral joint. And as you can see in this small picture, and I think I'm very happy now, yeah, a little bit. So this is the rib, this is the costovertebral joint. It's always connected to two vertebral bodies. And this is the amazing part, because this is the intra-articular ligament between the rib, the head of the rib, and the disc. So the ribs, especially with traumas, are so important because we fall, children fall, we bounce to something, against a tree or a door or whatever, and the rib is not moving properly, has immediately via this ligament impact on the disc. So in a lot of cases we work more specific with the ribs than we work with the thoracic disc itself. So we have techniques for the thoracic disc, but we are not we're not happy with the direct disc thoracic effect of it. So we work more with of course with the organs, but also with the rib itself because of this intra-articular ligament. So as you can see on the left, there's only less than 1% this herniation, so it's very rare, around 40 to 50 years, most frequently in men, and most of the time it's disc herniation is asymptomatic. So that's and most of the time it's an injury in the past that would play an important role to have that. Particularities. The cervical disc is huge compared to the vertebra. So because there's a 3 millimeter, and there's a 5 millimeter, and there is a 9 millimeter of the different disc. But of course, the height of the vertebral body is also very, very different. What's very important, most people forget, it's very, very easy, is that the existence in the spinal column, where's my arrow again? In the spinal column is this, this is such an amazing picture, with the vertebral artery and the vertebral vein. You don't see a lot of pictures where the vertebral artery and the vein are in the transverse canal drawn. Most of the time it's only the artery or only the vein. In this case it's both, so that's nice. And the weak point in the cervical area is again C5, C6, mostly on the left side when people are right-handed. These problems could cause tension in the brachial plexus. So we have also techniques to combine the disc with the brachial plexus. And the huge difference between the lumbar and the cervical area is the existence of the spinal cord. Because as you know, in the lumbar spine, around L2 it stops. You have the cauda equina, but in the cervical area, you have the spinal cord. Through the whole area, you have this spinal cord. So we are much more sensitive with our disc technique in the cervical spine than in the lumbar spine. That's why it is also in the end of the course. So we have already some education of our fingers. Important also in the cervical disc, in the cervical area, especially in the cervical vertebral body, is that the uncus on the side, I will show you a nice picture later, starts growing between 8 to 9 years of age. Before that, it's not there. And it's very important, it's just a little bit like the disc, is protecting the disc until we were older. So, we'll go further. Yeah, nice picture again. So you can see here the, oh, where is my, so here is the uncus. This is it. So on the side, you can see here the whole picture. So this is a disc. And then on the side, you have this, the uncus, this kind of disc going up like a pyramid on one side and a pyramid on the other side to help to create this bassin. You can see it here very nice with the nucleus pulposus here and the annulus fibers here. and it's going up. So it's not easy for the disc just to go outside. It's more or less, it's protecting by the uncus. So that's only started around 8 to 9, 7 years old. Cervical herniated disc causes is more or less the same as in the lumbar area, of course. Disc generation over time. When it ages, the disc, it loses its hydration and becomes less flexible, less endurable. And it comes all kinds of tears come inside, and it can develop this disc problem. And besides that, of course, you have this problem with the end plates, that there is not enough nutrition, and there's not enough removal of the waste products. So it's a combination. I will talk about it more in detail in the course itself. Then, of course, you can have spondylosis arthrosis, especially with the oncovertebral and the facet joints. Nice picture show you. And trauma plays an important role in the cervical area. A direct impact on the spine can cause a disc to tear or herniate, especially in the cervical area. So, there it is. So this is nice. I hope you find it as nice as I have. So this is the disc, the Annulus Fibrosis. We have the annular tear. It goes in posterior lateral direction. And you have the spinal nerve in this area. Then there are two possibilities, because in this area you have the uncovertebral joint, but that could also be degenerative. So there could also be hypertrophy. So that could also push on the herniation, could also push on the nerve. And on the other hand, that happens also, of course, in the lumbar area, that there is the facet joint could be also degenerative, and that could also squeeze the spine, the nerve, the spinal nerve, And if you are very, very unlucky, you have on both sides the facet joint and you have this uncus. So from both sides, the nerve, the tunnel becomes narrower and narrower and narrower. And then you have a third possibility, is that if the disc loses water, it becomes lower, and then there's also compression from the top. So from three areas, the spinal nerve is compressed, is under pressure. Also here, we are very aware that there is a congestion in the venous system, so we need this venous system. You can see here's a great picture on the right lower part with all the veins to help to protect the spinal cord, but also to protect and to enlighten the spinal nerve. So, of course, in the cervical area, the venous system plays also a very important role to let it healthy. Interesting that spicy foods gives a dilatation effect on the venous system. So, if you have a little bit pain and you eat spicy foods, the venous system dilated, and you get more pain because it's compressing the spinal nerve itself. Okay, a little bit for the treatment, just to show you what we were doing. This is nice to work here with the disc in side lying. Most of the time we do that in side lying. We can combine that when we move the arm downwards. We incorporate the brachial plexus, and this is the same picture. And also we work a little bit to release the pressure, do a traction. The last part, to speak a little bit about the venous drainage of the cervical spine. So on both pictures, but on this picture you see such nice that there are so many veins around the neck, much more than we knew of. So we know, of course, the vertebral vein, but we have also a little bit higher the occipital vein draining from the head, and the internal and external jugular veins, or the big ones and the little smaller ones, and all that is draining into the subclavian vein and the brachiocephalic veins. So everything is draining in this area. On the left picture, you have in this corner this venous triangle, you have this drainage, and I hopefully, there it is. So all this venous system from the neck, so from the neck itself, but also from the head, is draining downward to the internal jugular vein, the external jugular vein, the vertebral vein, and that goes all together into this subclavian vein. So in this corner, it's a very, very important part of the venous system. And just like in the lumbar area, the discs, the whole cervical area, and also the head are dependent of this of this venous system. And what's interesting, and of course we will speak, Jean-Pierre will speak more about that in the brain course. It's very important that those veins, just the internal jugular, the vertebral vein, and the external jugular, and a lot more small ones, are working great, because that also helps to enlighten the pressure of the brain itself. So it protects the brain, but it also enlightens the brain. So the negative pressure in the thorax is important, because the negative pressure goes through the veins and enlightens the brain itself. So when you have, for example, a baby, don't jump directly on the head, but also check the thorax, because if there are rib fixations, if there is something going on with the sternum, it gives you problems with the negative pressure, and that has probably a big impact on the head, because it's a little bit congested. So what I said before, the key point is the venous angle. It's this angle in this corner. So the subclavian vein, the internal jugular vein, and then in this corner you also have the entrance of the lymphatic duct. The left one, of course, on the left side. It's fine, that's nice. Yeah, left one, oh, left, and you have the right one. And the left one is very, very interesting, because 3/4 of the whole body is draining, of the lymph system is draining in this area. And only 1/4 is draining in this area. So be sure that you test this when there are some problems with the head, with the brain, some problems with the neck. And also when there is something going on with the pelvis area, test the left side, because the whole thoracic duct from the legs, from the pelvis area, is draining into the left subclavian vein. Yeah, so you have here on the top the subclavian veins and the drainage of it. Nice picture, because I will show in the course also a technique to work with this area. To work with we start with using the bronchus, and then we work on this here, the entrance of the what is it? Of the azygos vein. Here, the azygos and the hemiazygos vein are the backup system of the vena cava, the vena cava system. So you always have a backup of a backup of a backup. You can see it here. Vertebral artery and vertebral vein, that's a lot. It's important, because the vertebral veins and arteries are, especially the arteries, are communicating with the circle of Willis. Very important, the blood supply of the brain itself. So of course we work in this course with this area, of course. But also in the brain course, we will have some techniques to work more specifically also with the carotid artery, and the internal carotid and the internal jugular vein, but also for the subclavian. So because the blood supply is so important for the brain itself. And of course, we have a special technique for the vertebral artery and the vein to give it's not a stretch, but to have an elongated effect on the vertebral artery and the vertebral vein, just to help to work, to let it move, to let it glide in this transverse canal inside the vertebral, inside the cervical spine. And again, if someone had an accident, a trauma, a car accident, All people think immediately about cervical spine, of course, but don't never forget the vertebral artery and the vertebral vein inside, because that's so important for the brain that the body will also always try to compensate with the muscles and the cervical spine to help to open this transverse canal that the vertebral artery and vein, and also of course the carotid arteries, can work properly. So thank you for listening. This was my short between lines, my short review, my short dive into this BICADD course to make you a little bit more excited, to make you a little bit curious for the discourse. And I hope to see you in September and to make you a little bit passionate and to say, okay, wow, I want to do this course. Kåre, if you are there,
I'm here. Yes.
Questions that are very urgent to answer?
So far, actually, I have monitored the chat and there has been no questions. So I can put it to the group. If you have any questions for Mark, we can take a few questions. So please write your name on the chat so I can ask you to unmute and we can have a question or two.
Besides Gerard, everyone can ask questions, but not Gerard. You're always eating, Gerard. Come on. So, was I so clear that no one has any questions, or no one is daring to ask a question?
We do have a comment from Yelena. You were mesmerized by your presentation. And then we have Lone Ross asking, how do you treat the skin?
Wait a second, because I want to see myself. How do I treat the skin? Is by
you can unshare the screen.
Unshare the screen. Stop share. Unsharing the screen. Hello. That's nice.
There you go.
So what you can do is to do a traction of the skin. So we're trying to feel that we do traction of the skin to the second layer, and we lift it up to feel where the tension is, and then we can use induction, follow and encourage the movements to release that. That's one part when you want to work directly with the skin itself, or you can work with the cutaneous nerve.
Okay, so Mark, that was a little bit difficult to see. Can you maybe show that on your forearm so that people can lift the arm up a little bit higher? There we go. Perfect.
So you lift it up, and you're trying to feel where the tension is, and where the tension is, you do traction and you use induction. I do a little bit exaggeration just to work with the specific area, and then you let it go, and you feel immediately that there becomes a release of this of the skin, and because there's a direct effect on the lymph system also with that, the lymph small lymph canals inside the skin. Other question?
Yeah.
There is no direct connection between the.
What Mark means on the cervical spine with key point is LT side on RT-handed patient. Not sure what that means.
No, me neither. I think it was in my presentation.
Tamim, would you care to explain that one?
Wait a second. I go also into the chat. Wait a second, if I can see this question.
Yeah.
What Mark means on cervical spine with key point is LT side on right RT-handed patient. Oh, C5, C6 on the left side is the key point for the cervical spine with right-handed people. So you see a lot of restrictions on C5, C6 on the left when you have right-handed people.
Okay, so there's another question. What about these disc prolapse? Is there a great effect? And I think Mark answered that with that we're focusing more onto the viscoelasticity rather than the prolapse itself.
Very good.
There's another question. What is the connection? Whoa. What is the connection between the piriformis and the bladder?
Partly it has to do with the innervation. Yeah, the piriformis is S1, S2, S3, and that's also for the bladder. So there's a direct nervous connection with the bladder and the piriformis.
Okay, there's a long one here.
Thank you. Thank you. Oh, here. Right, I read it.
Yeah.
Was there a specific focus on L1, L2, GJ junction, I think, because of the key vascular components ventral to this area? Was there a specific focus on L1, L2?
That's the disc you were saying about, right?
Yeah, yeah, the disc in standing position from L2 and also the sinovertebral arteries that goes to L2. You couldn't check. Yeah, I'm not sure about that. She's right. Was it she? No, he is right. Sorry. Yeah. That is more or less on the same level. And it's also the celiac artery, but also the superior mesenteric artery at that level. So there is a lot also going on from the inside. So it's probably not only L2, it has also to do with the posterior longitudinal ligament inside, because you have a superficial and a deep layer. So there are more options why L2 is so important with that. Is there more?
Super. All right. Thank you so much, Mark. I think there's no more questions right now. And thank you for taking extra time when the techniques weren't working in the beginning. And it was an excellent presentation. Thank you so much.
My pleasure. And if there was no technical problems, I was done at 8:30. But now because of technical problems, it's 9. So it's more or less the same. So no problem. Good. I was delighted to do it. And I hope to see you, of course, but everyone also in September with the BICADD course, but then in real life and to touch each other again.
Yes, that's what we really want to do, be in the same classroom again, right?
Yes, for sure, yeah.
And to everybody else, I will be sending out the information about the class, and also this video you will have access to after, so you can review the talk that Mark has just done.
Perfect.
So again, thank you, Mark, and thank you everybody for showing up. We'll end this class for today.
Kåre, can you also send it to me, please, this recording part?
Absolutely, I will do that.
Thank you very much, and have an exciting evening. Thank you very much.
Yes, you too.
Bye-bye.
Bye, everybody.
Bye-bye, everybody. Bye-bye.